And so the core negative thinking that we see with depression, often associated with negative thoughts about yourself. So I'm a failure, I'm broken, I'm unlovable, I'm a disappointment to everybody, about the world, like the world's falling apart, nothing ever works out, everybody's out to get everybody, no one really cares, everything is hopeless and not to exert effort would just be a waste, learned helplessness because nothing can be fixed. Change is not possible. Thoughts about the future, it's not going to change. This isn't just temporary, and it doesn't matter what I do, what anyone does, like it's still going to be bad. And the truth is, if that is true, of course, like if nothing can get better, it is definitely a waste to sit to keep trying to change. And so that is valid. But the good news is there are a lot of different creative ways to create change. But like an animal in a lab that keeps getting electric shocks, like eventually they will stop, because at the very least conserve your energy. If whenever you try to do something it doesn't work and you try again, at least stopping, conserving your energy is a very appropriate move. Any thoughts about that? So kind of old school basic CBT when it comes, the CBT and Becky and CBT really started with depression. So if we kind of think about the CBT triangle which was very innovative, that how thoughts can impact feelings, which impact behaviors, and round it goes. And so we can intervene at each of these different points. We could intervene. So if you're thinking things will never get better, that's going to lead to feeling hopeless, sad, which is going to lead to what's the point of doing anything? I'm going to stay in bed, which is going to lead to feeling I'm a loser. So they all interconnect, thoughts, feelings, behaviors, and we can always intervene to make contact with and explore the behaviors that are engaging in the thoughts and the feelings. So we just have a little bit more control over which of these do we as humans with ourselves have the most control over: thoughts, behaviors, or feelings. Anyone?
Behaviors.
Behaviors. Yeah. So changing what we do is the thing we can control the most. Our thoughts, it might pop up. We can't change the thought that's going to pop up. Like, you're a loser. What are you talking about? Everyone thinks you're a loser. Like, our thoughts pop up because our brain is supposed to be scanning and thinking but we can change how we relate to our thoughts, and we could change if we decide to get deep and engage with those thoughts or notice them compassionately, and then choose to that may or may not be true, but I do need to do this right now. And then our feelings and emotions, we tend to have the least control over, and that's normally the thing that people want to change the most. Like, they come to therapy to feel better. If only I could just feel better, then I go to the gym, and then I would play more with my kids. So that's normally people's starting point when they think of therapy, is to feel better. Even parents will tell their kids, like, oh, we're going to a feeling doctor. I'm like, I don't know about a feeling doctor, but maybe like a behavior doctor, and then the feelings will come along. Sometimes they won't, but the more we learn to live life on our own terms, it's just we're less fused with the feelings. And so we do have control over them, but not in the way that people necessarily imagine they will be controlling their feelings. That feeling might still be there. It's just not everything because there's all this other stuff happening. So that's CBT triangle. And the most reasonable approach when everything does feel hopeless and it makes sense is leading to this shutdown and this conserving of energy, and not wasting actions. If it feels like nothing's going to change, why try to meet someone new? Why actually try to learn something in your class? So that is often a step. That's normally by the time clients come in and get help, they've sort of entered a state of not doing, where the hard feelings, the hard thoughts have led to lack of engaging. And this is, whether it's anxiety disorders or depression, that avoidance cycle is at play. And so I always point out overlaps between different disorders because it's really important that we remember that if we know how to treat GAD, we know how to treat depression, we know how to treat OCD, they're all interconnected. And in fact, there's a unified protocol that was, I don't even know, maybe 10 years ago, created, that it really is the same underlying mechanisms of experiential of hard feelings, experiential avoidance of hard stuff, and then life kind of shrinking and getting smaller, and unhealthy coping behaviors that is across all mental health conditions. And so, yes, we're going to do some different things with each condition we treat, but at the same time, we're doing so much of the same thing. And I find that reassuring, because it's hard when it feels like, in fact, we have to do 20 different protocols with there's 80% is the same that we're doing. So the avoidance cycle with depression is increase in negative thoughts, like it's fall is coming and summer's ending, and that was my chance to try to meet someone, and it's going to get colder and I'm never going to go out as much, and I might as well just assume this year's not going to work. I'm always going to be alone, never going to find someone. Avoidance. So like, why make an effort or do anything? Okay, I'm going to watch TV and distract myself and feel some relief. I didn't push myself to go out, try to go on a date, but then increase in negative thoughts like you're so weak, la la la, and then the short-term relief doesn't come after the increase in negative thoughts. I moved. It was the more avoidance, and then I made this last night. So it was the more avoidance and then short-term relief. So you do not get short-term relief by the increase in negative thoughts. Lisa, Susanna, will you remind me later I have it in screen share. I'm really trying to resist the compulsion right now. Like,
Susanna, you can actually change it. I changed your anxiety to generalized anxiety.
Thank you.
I'm feeling want to go in there and change it.
Like adjust right. I'm like tolerating wrong, but feel free right now, like whenever, to change that. It's wrong and I'm living with it. You don't like it at all. Okay. The good news of what we do is we get to like constantly do exposures and challenge ourselves and learn, heal with the people that we work with. So we get so much opportunities to keep healing. So kind of back to the similarities between what we were talking about with GAD, which we were linking to OCD and other anxiety disorders, ERP for depression. And I was actually Googling this. I'm like, does anyone ever talk about it that way? I actually didn't find anything specific to it, but it made sense to me. So I'm going to share it with you. But when you think about what is the exposure, we're always exposing ourselves to that, to the fear. And so the thing that you're fearing in depression is loss, is taking a chance. Like if I do this and it doesn't work, that's just I'm going to be all the more hopeless. So it's like the thing that you're fearing is taking a risk and then failing and then feeling even worse. So like exposure to like taking a chance again, exposure really to living, because it feels safer just to at least avoid, and then you don't have to risk that next shock and then more feeling bad. So how do you expose yourself to taking a chance, to engaging, even though it might not work out? But that's still a moment that you're engaging, and that counts too. So that's really the thing that you're exposing. And when we talk about behavioral activation, that's what we're doing. It's really, you don't engage. Behavioral activation isn't because like you want to do that thing. It's really an exposure to doing it anyway, even though it feels really scary to do something. And then the response prevention is noticing and then disengaging from the rumination. So it's going to come up like you're a loser, automatic thought, but then ruminating like, yeah, you've always been, and like, well, maybe that's because you're only your parents ever cared. And then that could be 3 hours past of ruminating about the intrusive thought. So noticing when that's happening, it's going to happen, but then choosing to compassionately disengage. Like, yes, all of these things may be true, and I'm going to just risk taking a chance again. So, any thoughts about questions, discussion around kind of applying that model when working with depression? It's kind of a big, vague question, but depression's big and vague. So, and I guess
Being a
I'll
bad
like, what does
Yeah.
it say it again, Susanna?
I like as you were sharing the CBT triangle too about it feels there's almost this like I don't know, it's like a negative lens, right, that gets cast over with thoughts, and it can be so the thoughts that or I'm failing just like sort of uh almost like a negative confirmation bias about like world events. I'm curious if people have thoughts on how can you try to really push the behavioral side with the exposures around. I mean, I know we talked about like behavioral activation, but like, is there anything to like what comes first? Whether you want to sort of lightly challenge lots of, like the world is scary, the world is bad, etc. I don't know. I don't have a fast point. No.
Yeah, well, it's hard because of that lack of but depression is sort of the opposite of mania, too much energy. Depression, we could just think of it in terms of energy load, because it's sort of like a bear hibernate, like nothing is
Yeah.
working. And so it truly, that low energy state of feeling like there's a huge weight on top of you. Like, in fact, it's not like, okay, so let's go for a run. Like, you're starting, someone does in fact have that very, very low battery, and they don't so like some of the behavioral activation, and we could kind of move towards that, is really, 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 really hard, because someone's going to be really, really, really resistant, because even though it's not helping to live the life one wants to live, that cozy dark blanket is really, someone doesn't want to remove it and go for a walk, because going for a walk feels really, you don't have the energy, and it feels really scary, like I'm risking trying, what a loser I am to protect, like it's vulnerable and
Exactly.
it's scary. And so doing the behavioral activation is super duper hard, and really being like I've had with clients on the phone, like, let's just put one dish together. If it's let's go into your kid, like seeing some of the benefit of virtual appointments is like, wow, like really sometimes seeing someone's despair in what's around them in terms of like laundry everywhere and like what if we just like we could do this together, like I'm gonna lift something with you, like take one item from the floor and just put it into your basket. Boom. And we're gonna do that together right now. Or I've taken like one bin with someone like taking garbage out or folding, and this is so hard, and so I think just going so low with it and doing it together also is probably critical. And I think we have David or
We
Suzanne
have
or
a couple
Lucy.
of comments, and then
Yeah.
Danielle has also raised her hand.
Yeah, whoever
David.
went first. Yeah, Susanna, you.
Well, David, you were agreeing, I think, with what Dr. Kissen was saying.
Okay. Anything you want to add to
Or I
the?
think Anna was before that, Susanna. I think Anna had a comment that it feels harder than GAD. Did I see that?
Yeah.
I'll
Oh,
be
yeah.
super quick. It's just that
Okay.
idea of like, I have so many clients with depression where it's just the energy sucking. That's the best way I can describe it, where it's even like some of the sessions are harder just because it's very, I don't know. It reminds me of the teenagers that we see where it's just like they have zero energy that they even want to use, but they do want to get better. And so
Right.
I stated here, like, some of my clients, they describe like, well, I just like to rot. That's my coping skill. I'm like, cool, great. In small amounts, like just like how anything is great. But I'm just, as you said, Dr. Kissen, like doing the small amount of like, I'll push them to go to a different area of their apartment for a
Right.
session. Like, okay, you're always in this spot, do a different one.
Right. And even
Or
so, I
like,
might even be like, can you, like, how heavy do your arms feel? Like 20. Okay. Like, what if we just raised, what if we see what's that like then to raise your 10-pound arms? Like, can we do that right now? So that fully counts. Like, and if you had 10-pound weights on you, maybe can we do this 5 times? Like, I'm not an exercise specialist, but like what is that like to create movement even when we're so stuck? And I just one thing I just want to show you guys, and then we'll go through the uh people's ideas, but just like I called it walk and talk therapy. I think this is on our website. We have it on our website that we do walk and talk therapy. And so, and you're always welcome to do that with a client. That sometimes when I have someone that comes in really depressed and I'm like, walk and talk, like if they just and they're not always going to be, it's cold. I'm like, let's just do this, and that might be the whole session of like, let's do this for 10 minutes. Then once we get going, and then, and let's just like, while we'll just go for a walk and like take turns. I see a tree. So if it feels like someone is just so stuck in the session, then, not necessarily trying to like speak about what's going on, but just getting things moving in different creative ways. So has anyone ever done like a walk and talk session with the client? How did that work?
we walked to Starbucks. We walked to Starbucks and we just talked about stuff. Any of my teenage girl clients, they love it because it's their, I was literally telling Sarah about this yesterday, like talking about how like they're like, whoa, this is not what I expected, and we're getting Starbucks. That's fantastic. And it even adds, like, I had a client where she asked if I could order for her, and I told her no. Like, it opened up that of like, cool,
Right.
that's your social anxiety, sick, great to know that. And like, there is a bit of like, we can't talk about everything because we're out and there's distractions and things, but also like just a rapport building a little bit, and it's a little bit more casual, and there's other people around, more energy than just a one-on-one room. But yeah, I do that a lot with younger clients, or like if it's really cold in the Lakeview office and I have someone I've seen for a while, we'll go for a walk, let's do something different, change it up.
And yeah, this is a creative, like when I think of behavioral activation, like the Catcade used to be across from our office. It's moved. Now it's like 10 blocks away, but it was cat rescue place and it was right across the street from our old office, and there was like 30 cats and video games, and I'm like, okay, we got to get things. Let's just get out of our head and into life, because at that point, talking, if someone's so fused, is going to be harder than like, what can we do? I had someone who, so I can't go on the dating apps. I don't have anything where for the pictures that we ended up. I'm like, all right, so let's go shop. Like, we went on Southport and we went shopping, and she bought something to wear and then we actually took some pictures that she put on her app. So in terms of behavioral activation, it takes a lot of different forms. Like, what does it take to get somebody moving and support them when they truly are that stuck and that much energy? How do we help boost them up a little bit? So these are great examples for you guys, because I know it's not a traditional, for some people, like, are you allowed to leave the office? Or and yes, we certainly can. Any questions on that? Actually, any of the logistics around what the example Anna gave or the examples I'm giving?
I can chime in.
Yeah.
I would say that's the one thing where I get like so envious of y'all. Like, I'm in Ravenswood right now, but I spend a lot of time in Wilmette, and there's times I'm like, okay, yeah, I want to do something like that, but because of scheduling, it's like, how do we meet somebody out?
And you can choose to meet at Old Orchard too, depending on the thing.
Yeah.
But it's a little bit like just walking. There's nowhere to walk from. You go on like a nature
Yeah.
walk.
Oh yeah,
Cool.
like, so Ryan does that a lot because we have that nice yard in the
Oh,
back
that's
and
so
things like
cool. He
that.
does?
So, yeah. Oh yeah, like there's so many times, especially as teens, you'll see him take people around.
Really? That's fun.
Yeah, it just for I remember one time I had definitely a somebody that really would have benefited from the same thing, like a Starbucks ordering for themselves, because that's a big challenge. And it was like, okay, we got to figure out how we're going to meet there. And then every single time I thought I had the opportunity, then like my schedule would fill up and I'm like, but they were able to do it without me anyway. So we were able to work it out. But no, I always like that opportunities available here for people to do so that's all. I really have to, I don't even know what my point was. There we go.
That you're jealous of Southport. I think that was your point.
Yeah.
My issue is all of my depressed clients are virtual. And so, and they also, when I meet with them, they have like family in the house. A lot of the times we're like talking about relational dynamics and stuff. And I can't like take my computer and walk, like we'll go on a walk together virtually. So I guess I need more ideas of like what to do when they're in that room.
We could play for a moment. Would you be willing to be a client?
Sure.
Cool. And I don't know what I'm gonna be, but let's see. Okay, so do you mind? So tell me a little bit what's going on this week. How did it go in terms of giving yourself just a daily, at least 5-minute walk just to get moving?
Yeah, I haven't really been able to get out of the apartment still. I work remotely. And so I don't know. It's kind of hard. Like my home and work is in the same space, and just like, I don't even just want to go outside. Like I didn't even go outside yesterday.
Yeah. And actually I have my window closed, but today is a little bit great as well. So I guess let's just start with now. If you kind of check in with yourself right now, 0 to 10, and you kind of use the word like feeling kind of heavy and stuck last session. So how, if like 0 to 10, if 10 was like the most heavy and stuck, like how do you feel at this exact second?
Maybe 7.
And where do you feel it? Like starting with your head, your shoulders, like what sensations stand out?
I think my shoulders, since I'm like at my laptop all day.
Anything else in terms of when you think of being at a 7 of heavy feelings? Shoulders.
It's just like super exhausted all the time.
Right.
Eyes
Exhausted.
and my head.
Yeah.
Yeah.
Yeah. Because you just, when you said exhausted, it was like, so
Yeah.
you think exhausted, your eyes. Tell me a little bit more about that when your face feels exhausted. Like,
I guess it's just like
right now.
could nap anytime.
Okay.
Want to lay down.
Just want to lay down. Like your energy is kind of moving you towards like,
Yeah.
if I could just lay down right now. Okay.
Mhm.
So if you're willing to do a little experiment, I am curious, 0 to 10, if I was gonna say, how hard would it be to do a jumping jack? How hard would that be?
Probably, I guess not that hard. Like
Not that
4.
hard?
Yeah.
Okay, why don't we just stand up and do one and we're not doing this to create change. We're just kind of exploring what it feels like right now to feel at the 7 stuck and what it would feel like. Okay. So
Okay. Okay.
let's actually do it.
I'm gonna do it right here. Okay.
Okay. Me too. I'm gonna do 2. Are you willing to do 2 while you're
Okay, I'll do another one. Yeah.
Okay. Huh. Okay. What did you notice about
kind of got my heart rate going a bit. Felt like maybe like kind of good to move my arms up.
It really did, by the way. I'm so glad that we just like I didn't even realize how stuck I was just feeling myself, to tell you the truth, because it actually felt. And so if you don't mind, I'm actually gonna, I think, stand for the rest of the session, because I didn't even realize that like I was feeling pretty stuck myself. Okay, so we could end the role play with that, and who knows what we would do, but that was true. Like that actually felt much better.
I was also, that made me think like maybe suggesting, hey, is there a place in your room that you could put the computer in so you could see? We don't all have a standing desk, but like a dresser, like
like a dresser, or like how about you just stack up some books? Someone might just say like, oh, I don't have people get very literal, like, oh, I don't have a standing desk.
Right, right. A lot of my clients are like in their bed.
Right. And so just even and then like what is that? And then I would just kind of play with that. And then I think Lisa was there, or Susanna, there was just a question on that, and then we could go through.
I had a question. Well, a couple.
Yeah.
I mean, she asked, "What if the client is resistant to moving?" Which is it's a good question.
It's a great question. And I would just I would start with, and like say I had somebody who had a disability, like I would also start with kind of having a baseline of who I'm also dealing with too. If I had like a 90-year-old client who's in, like I would maybe say like, depending on like the starting point, I wouldn't necessarily start with a jumping jack. Depending on, I might just say like, what is it like to like lift your arms up to this? But if somebody's like, I'm not moving at all, I eventually, if someone was so resistant, like I just have some people who sometimes that's like a compulsion of like, if someone tells me to do something, I don't want to do it. And then we'll talk about that. And then so there might be something to that as well, if someone is just so resistant to any suggestion, but eventually that wouldn't work if someone just isn't willing to play at all at a level that would be a fair zone for them.
Yeah. Or maybe, I mean, I don't know. I'd be like, well, would you be open to like doing would they stretch? You know, if they don't want to move their arm, I don't know, maybe there's some way to
like, how about if you just like took one, like, what would that be like? Like, I don't care what a baby step is. And that to me, everything is a step. But if someone isn't willing to do anything, that's okay. It just means there's probably a better use of their time right now than therapy. And then whoever, you guys could go in the order of the comments. So whoever was next, I just don't have them open.
I didn't know if David wanted to add anything. I know Sarah S. and Danielle both had some thoughts.
Cool. Sarah, you want to jump
There you go,
in?
David.
Sure. I just commented when we were talking about the behavioral activation on body doubling, which is kind of what you were describing doing, I think, with kind of like, well, what if, we just kind of did this together, even if it's like a virtual session, and that kind of helps to lower the activation energy.
I've never heard of that, but I really like that. What is that from?
I just had a friend like who used that term.
I really like it.
Yeah, and I was like, oh, okay, stealing this from my clients.
So it's like that mirror, those mirror neurons. Like I can, by you are really helping to lift someone up because their brain is seeing that motion. And so like I really sometimes I really like to like really imagine that my energy is helping their energy. So it's cool.
Exactly. And then I think I also wanted to add to the walking piece that there's like a lot of science and like research behind obviously like walking, regulating the body, which I think is what you were kind of getting at, but also if there's anxiety, you don't have to make eye contact always. And so especially with teenagers, you can get them to like say maybe more than if they're just like staring and in the room.
Right. Or like conversations in the car with your, parents will say in the car with their kids and I mean, it makes sense. Like animals aren't normally the times they're staring directly at each other, they're about to like attack or it is very intimate. So,
Danielle, thanks for waiting. Sorry, I know you raised your hand.
Yeah.
Go for it.
No worries. What I was raising my hand about before isn't really, I mean, I guess it could be relevant, but
relevant.
I was just saying, like, when we were talking about ERP for depression versus anxiety, is I think of it more as like when you do it with anxiety, like a low level exposure, like step A. I think of like the first step for depression is like you wouldn't go from A to B, you would go like A1, A2, A3. Like the steps are just like microscopic almost, like they're just so much smaller. But like they're like, if you were thinking of like a high exposure, be like for someone with social, or a low exposure for someone with social anxiety, like going to Starbucks and ordering for themselves, that would be like a high exposure for someone with depression. So like you just kind of have to think of it in terms of like capabilities and like where they're at, but also what we were just talking about is I've suggested having clients like think about what it would be like first.
Picture yourself like
picture yourself, what would it be like to stand up right now and do a jumping jack? What would come up for you? And then talking about why we think that would come up and be like, well, then maybe it won't. Let's like
let's do an experiment. I love
or
that.
me doing it first, especially with like the teenagers and the kids, like seeing me do it and it not being so bad, then like they're like, oh, that's kind of fine, I'll just do it now too.
I really like those examples, and I think there's something to going so slow that it's just very validating. I think that's some of the hard things about depression. Someone's like the last thing someone needs to hear is you just need more what's that bad word that we should never tell people, that like someone's family might like more determined, like more.
Are you thinking of like grit or something? No.
Or willpower.
Willpower.
I would never say willpower. I've banned it from my mind. I'm like, what's that thing that we should never say? But like, yes, we like to say just do it, take your feelings with you, but with such a deep understanding of just how hard this is to do all the things that you're doing. I think that difference is validating, it's compassionate. It really just shows this is so hard, and I believe in you, and like, wow, that one step is really, really amazing, like truly. So I think when we approach it that way, it creates a lot more give to it, to behavioral activation. Lisa?
I just wanted to also, sometimes we talk about medication with some of our conditions here, and even just thinking about Anna's clients that she's bringing up, I wanted to at least just highlight the drop-in hours that we have with our nurse practitioners here. But like, if you have questions about clients that you're just not, maybe medication will help them.
Yeah.
slowly
No, thank
move
you, Lisa,
something,
'cause
something like that. Yeah, I just
Yeah,
was thinking.
no, I was thinking of that when I was making slides. In general, from mild to moderate symptoms, CBT, but the second we're starting, moderate to severe, and even like if someone's interested in more tools in the toolbox for mild depression, medication alone might be the right path for them, and that's great. Whatever is helping them to get into their life in a way that makes the most sense. And for some individuals, that might be like, I'm able to do, but if it feels this hard in 2 months to keep going to work, that's when I'm willing to consider adding medication, but like sort of just continuing to have those conversations with clients. Most of our clients these days seem to come in with medication, but some not. And just knowing, having those, seeing where somebody's at if they're not on medication, and then deciding what your communication path is going to be. So for someone who's really resistant and really feels like they should be able to do it alone, that might take longer just to talk to them about what that means. And if you needed glasses, bye, Jessica. If you're not seeing clearly, would you be so resistant to glass? And so I think just keeping in mind this really great tool in the toolbox along with CBT, and then for each patient, depending on their stuckness, seeing where they're at with on medication, considering medication. Yeah, Lisa, thank you for bringing that up. And we have great medication prescribers. If you just want to brainstorm a case with them, they're available to share information or offer some guidance. Well, we could kind of wrap. And then we could pick up next week with the